So we proceed to the next presentation. The next presenter is myself. Welcome everyone again. Today we will talk about imaging after the Starnes procedure and preparing for the cone operation. My name is Tarek Alsaied and I am one of the cardiologists here in Pittsburgh. I'm one of the cardiac imagers. All right, so in this presentation we will review the interstage Epstein anomaly or the post-Starnes anatomy and physiology. Then we will proceed to the non-invasive evaluation for these patients, including evaluation with echo and the importance of reviewing the newborn studies in these patients. And then we will talk about the utility of echo to evaluate RV function and the fenestration gradient after the Starnes operation. And we will talk briefly about the use of cardiac MRI, which allows quantitative, volumetric, and flow assessment in these patients, and also gives us high-resolution anatomic evaluation for these patients. And in order to do so, we will go ahead and discuss a journey of one patient who was born with severe neonatal Epstein. So this patient was born with severe Epstein's anomaly and pulmonary atresia. And as you can see here, the right atrium is severely dilated. This is actually the level of the atrial septum. The left atrium is pushed, and the right ventricle and the left ventricle, the right ventricle was severely dilated, the left ventricle was compressed. And then when you look at the chest X-ray, you see this wall-to-wall heart with severe cardiomegaly in this patient. So this patient had severe cardiomegaly, had respiratory compromise as they were born, was very hypoxemic, and had decreased cardiac output. And due to that, she was cannulated to ECMO right away, and the Starnes operation was performed immediately. This is just a look at her tricuspid regurgitation, and I think you agree this is beyond severe. This is more like what adult cardiologists now call torrential tricuspid regurgitation, where the regurgitant jet is so wide and the right atrium is very severely dilated. So this is a week later, and she underwent a Starnes operation with RA reduction and a BTT shunt. And you can see a week later on her X-ray, her heart is a lot smaller now. She's decannulated from ECMO. And you can see also that that Starnes membrane is right here. And there is a two-fro flow across that Starnes fenestration. And you can see that the right ventricle now is decompressed with normal left ventricular function. Just talking a little bit about the anatomy and the physiology of the RV exclusion in the Starnes procedure, and that was discussed very nicely by our previous speaker. You can see that with the Starnes operation, the surgeon will put a fenestrated patch, usually a 4-millimeter fenestration. And in this MRI here, you see the normal function of the left ventricle. You see the severely decompressed right ventricle. And the wall motion of the right ventricle typically is severely depressed post-Starnes, but that's just because of the loading conditions of that right ventricle. And you see the to and fro flow across that fenestration. And then if we look at the original paper of the Starnes procedure, you can see that the outcomes of the patients with fenestrated Starnes, which is this line here, were superior to other types of neonatal repair, including the non-fenestrated Starnes that I don't think anyone does, and also the biventricular repair or like the tricuspid valve repair performed in the neonatal period. And thus, as Dr. Konstantinov mentioned in his previous presentation, the Starnes operation is now the operation of choice for these patients with severe Epstein's or severe neonatal Epstein's. However, from the same paper, there was this statement here that the downside of the RV exclusion procedure is the commitment to the single ventricle Fontan pathway. And I think that paradigm has shifted, and we're going to talk more today about how Drs. De Silva and other surgeons in the world are now converting these patients to a biventricular or 1.5 ventricular repair. So let's continue with this patient. So this patient had a BTT shunt initially. You can see her saturation initially was in the 90s, and then the saturation started to drift down. And at age of 3 months or so, we, Dr. De Silva, elected to do a bidirectional Glenn operation. She did well after that, and then fast forward, now she is 18-month-old. And you can see we did a cardiac MRI on her. And you can see on this cardiac MRI, oops, sorry. You can see on this cardiac MRI that her right ventricle is decompressed here. You can see that there are some like tricuspid valve leaflets here. And then this is an apical stack, and you can see that the right ventricle has decompressed, and there is a fenestration in the Starnes membrane. And looking here at the cardiac MRI as well, you can see that the glen is patent. This is the glen anastomosis here. The branch PAs has grown nicely. And on this 3D reconstruction, this is the right ventricle. You can see she has pulmonary atresia, so there's some interruption here between the main pulmonary artery and the right ventricular outflow tract here. So here we were left with a decision. Should we go ahead and do a Fontan operation on this patient and complete the single ventricle palliation, or should we do the cone after Starnes operation? And in this case, we proceeded with doing the cone after Starnes operation, leaving the glen in place, so 1.5 ventricle repair. And this is one of the original papers from Drs. Da Silva. Dr. Dobson was the first author. And it kind of like speaks about the cone after Starnes operation. But for this talk, I want to focus at the preoperative imaging assessment for these patients. So in any patient who is undergoing the cone operation or cone after Starnes operation, there are some imaging factors that were predetermined by the surgical team and prior authors that are important for the pre-surgical planning. And these factors are if there is tethering of the anterior leaflet of the tricuspid valve to the RV wall, the angle of the tricuspid valve rotation that can be measured by echo or by cardiac MRI, as you can see here, the septal leaflet morphology, the displacement and attachment of the inferior leaflet, the number of the tricuspid valve orifices, the type of the distal valve attachments, whether it is focal, hyphenated, or linear, as Dr. Anderson mentioned this morning. And then one of the things that we tend to measure is the Starnes regurgitant jet velocity, and we measure it to estimate the pressure that was generated by the right ventricle. However, this was not considered a key factor for the surgical planning in these patients. Similarly, the RV function post-Starnes tend to be like the RV wall motion tends to be depressed, but that's with a certain loading conditions, and the RV function tends to get better after Starnes. So we don't use that for patient selection for cone post-Starnes. And to continue with this paper, the paper included the first 6 patients, and we characterized them nicely by imaging. And here is to say that, like reviewing the neonatal echocardiogram is very important in these patients to get all these anatomical details. And sometimes, like in our patient here, you can see that we use the TEE as well. So this is the tricuspid valve leaflet and the attachments to the RV free wall here. And we sometimes can use cardiac MRI to determine these characteristics. So to summarize that paper, and you see the TEE here, you see the tethering of the anterior leaflet of the tricuspid valve. And you see the cardiac MRI, and you see how there are some focal attachment of these tricuspid valve leaflets. So to summarize that paper from an imaging standpoint, the key imaging parameters to be reviewed are the tethering of the anterior tricuspid valve leaflet, the angle of the tricuspid valve rotation, the septal leaflet morphology, the inferior leaflet displacement, the number of the tricuspid valve orifices, and also the type of the distal valve attachments. And then other imaging points, including the Starnes fenestration regurgitant velocity, were not predictive of the RV suitability for the cone operation. So you can have a low pressure or a high pressure, and the RV can still be suitable for cone conversion. And also the preoperative catheterization, as Dr. Kreutzer will mention in her presentation, the RV pressure was also variable in these patients and was not used to reliably assess patients for selection for the cone operation. This paper, we will hear about it later during the presentations today by Dr. Ashraf and the Silva team. And you can see that this paper also looked at further experience with the cone after Starnes operation. And from an imaging standpoint, the pre-Starnes echocardiography is really important. Cardiac MRI can be really important in these patients, and it allows us to evaluate the valve morphology and the RV wall thickness, and these are important factors for the surgical planning. However, the preoperative cath, CMR, and echo measurements of the RV pressure were very variable, and they were not reliable for selection. Similarly, for the RV function or wall motion tends to be severely depressed post-Starnes, but gets a lot better after the cone operation. And based on that paper, there is this elegant algorithm of how to approach these patients, like our patients who required the Starnes operation in the neonatal period. And you can see our patient actually had pulmonary atresia as well. So we depend on the pulmonary valve here to decide the next steps for the patient. So in patients with pulmonary atresia or severe pulmonary stenosis with a small annulus, Drs. Da Silva, typically like what happened in our patient, will perform the Glenn operation, typically at the age of 4 to 6 months. And then later on, they will come back and do the cone operation and pulmonary valve repair or an RV to PA conduit, typically at the age of 12 to 18 months, as was the case in our patient. However, if the pulmonary valve is normal, then we wait till the age of 5 to 6 months, and then Dr. Da Silva will come and do a biventricular repair with the cone operation, and we'll try to come off bypass. And if the RV does not fail and the patient does well, as you can see, that's a common case, then we don't perform a Glenn at the same time. So back to our patient. So in this patient, we elected to do a Starnes takedown, the Da Silva cone operation, and reconstruction, or like a transannular PA-plasty with monocusp valve and a fenestrated ASD closure. And what you can see from this post-op echo, the tricuspid valve function was normal post-surgery, so there was only trivial tricuspid regurgitation, no stenosis, and the RV function has improved nicely. And you see that also by this cardiac MRI, where the RV function, as you can see here, has improved significantly after the procedure, and it's now normal. You see the monocusp as well, and you see that the Glenn is patent, and you see the nice connection between the RV and the main pulmonary artery here. That was the reconstructed RVOT here. Just to emphasize this from an imaging standpoint, it's really important to look at the newborn echocardiogram to evaluate all the anatomical details of the tricuspid valve. And you see, again, this severe tricuspid regurgitation. And that's the post-op result after the Starnes takedown and doing the cone with only trivial tricuspid regurgitation. And we have some long-term follow-up on this patient. So this patient is now 6 years old. She's doing really clinically well. She's attending kindergarten, and her RV function remains normal, trivial tricuspid regurgitation with good flow across the pulmonary valve. And we also did a cardiac MRI on her, also showing a good RV function. You see here the cone or the reconstructed tricuspid valve. You see the tricuspid valve en face as well, and you see that there is good antegrade flow across that tricuspid valve with only trivial regurgitation here, and good antegrade flow across the pulmonary valve. This is just to look at her pre-cone cardiac MRI, and what I want to highlight here is that you can see that pre-cone, even with cardiac MRI, the RV is decompressed, and the RV wall motion is severely depressed usually in these Starnes, and that's common. We don't use it for the selection, and you can see in this patient, the RV function nicely normalized after the cone operation with normalization of the RV size as well after that Starnes membrane was removed. So with that, over the last 15 minutes, we talked about the interstage Epstein's anomaly post-Starnes, which represent a unique physiology that can frequently be transitioned to a 1.5 or 2 ventricles. And we talked about the algorithm for that, and that multimodality imaging assessment of the tricuspid valve morphology, the RV size and function, RVOT, and pulmonary valve can assist this complex decision-making in Epstein's anomaly. And with that, I want to thank all of you. I want to thank Drs. Da Silva and Kreutzer from the Epstein Center and all my colleagues, especially Dr. Adam Christopher, who helped me a lot with these slides. Thank you.
Tarek, that was fantastic. I wanted to ask you, do you think then that the RV and diastolic volume index by MRI does not have any predictive value in determining the ability to do a biventricular versus a 1.5?
That's an excellent question, Jackie, and I will also ask this question to Dr. Da Silva, but we have seen really small RVs post-Starnes that come back and become really of good size. We've seen that in multiple occasions across the experience. So I will argue that so far in the experience, we have not seen a good correlation between the RV size or function pre-op and how the RV will behave post-op.
Thank you so much.
Thank you. Our next speaker is Dr. Jackie Kreutzer. Dr. Kreutzer needs no introduction. She is our endowed chair of pediatric cardiology here at University of Pittsburgh and one of the finest interventional cardiologists in the world. Welcome, Dr. Kreutzer.
Thank you.